Hey guys, so today we're going to talk about the 8 P's of intubation. So we're going to just start with the basics. We don't immediately intubate everybody, right? So what steps are we going to take to determine what we need to do next? Our primary assessment. So the primary survey, which should be done on all patients, includes assessing airway and breathing, and circulation, disability, and exposure, of course. But our focus is just going to be on the A and B, so the airway and breathing for right now. We start with the airway. We want to assess if the airway is patent or being compromised by foreign bodies, such as vomit, blood, secretions, etc., or if the patient's ventilation is poor enough that they can't maintain a patent airway. We're going to clear the airway with suction if we need to, and we'll relieve any snoring respirations to start with a jaw thrust or a head tilt chin lift, right? Clear that airway, make it open. Once we've assessed the airway and any interventions are done and reassessed, we want to make sure that anytime we do something, we reassess if it worked or didn't work before we move on. Then we go to breathing. So airway, assessment, intervention, reassessment, things have improved. Now we go on to assessing our breathing. When we do that, we want to look at the chest and observe the rising and falling for normal respirations. Listen for air movement. Is the breathing pattern normal? Is the rate normal? Is it too fast or too slow? If the patient's not breathing, or if they're breathing too slowly, then you can consider using a BVM to manually give breaths since they're unable to do it on their own, right? You can use OPAs or MPAs to help assist you to keep that airway piece open, because let's say you're doing a jaw thrust. Well, it can be kind of hard to do a jaw thrust and do masking. So you put an OPA or an MPA in, that helps to keep your airway open. Now you can focus on your masking, that's your breathing. Now you've got the whole picture together, all right? Reassess after you do anything. Again, so if you started bagging, reassess. Are your manual ventilations effective? You're looking for chest rise, good color change in the patient, improvement in your SpO2, your end tidal if you already have that going. So let's say you do some of these interventions and then it's like, well, when do I actually move to intubation? So there's 4 indications for intubation: failure to oxygenate, failure to ventilate, failure to protect the airway, and failure to improve. So failure to oxygenate occurs when there is no improvement in your SpO2 despite medications and non-invasive airway maneuvers or techniques. Failure to ventilate occurs when air exchange just isn't happening. So you could think an apneic overdose. They haven't been breathing, that air exchange isn't occurring. Our end-stage COPDers, they're having a really hard time ventilating, getting air in and out. And just because you come in and ventilate for them doesn't mean that you want to be bagging them for hours on end. So think about that overdose. If we've passed the point of Narcan being something that's going to be beneficial, now they're so grossly acidotic that they're still continuing to not breathe on their own, we're not going to continue to manually bag them. They're going to need to be intubated. Failure to protect the airway occurs in patients that are unresponsive and just can't protect that airway. They might have blood, secretions, vomit in their airway, and they often don't have a gag reflex, which is why they can't protect that airway. And finally, failure to improve. That's the last indication. And that refers to patients that have an expected clinical outcome that would require intubation. So you could think about a patient that you know that is going to be going directly into the OR, and they're going to be intubated for that, especially some of your trauma patients, right? If you know that the thing is going to happen and you're in a safe and appropriate place to do it, then that is an indication for doing an intubation. So in our mysterious scenario that we're coming up with for tonight, we've decided that we're going to intubate our patient, right? They met one of those 4 criteria. There's a lot to do, a lot to think about, and a lot to plan for in order to have a successful intubation. And so the 8 Ps are something that can help you remember the steps and all the important things that need to be done. So this is just a very brief outline of what the 8 steps entail. So patient assessment and preparation, positioning, pre-oxygenation, your plan for failed attempt, pause, paralysis with induction, placement with proof, and your post-intubation management. So we're going to break down each one as we go through this. So patient assessment and preparation of equipment. You want to ask yourself at the beginning of any intubation, do I anticipate this intubation to be challenging? Patient assessment is extremely important, as recognizing your patient is going to be a difficult intubation can help you better prepare. It can alert you to needing additional equipment readily available, which we'll talk about more in the next slide. The LEMON acronym can help you anticipate a difficult airway. L stands for look. Look externally. Look for external marks of difficult intubation, such as a large body habitus, a short neck, small mouth opening with loose teeth or prominent teeth, and jaw abnormalities. Evaluate your 3-3-2. Can the patient fit 3 fingers between their incisors? Is the mandible length 3 fingers from the mentum to the hyoid? And is the distance from the hyoid to the thyroid at least 2 fingers? If any of these fall outside of the 3-3-2 rule, anticipate a challenging and potentially anterior airway. You can see that this is an example looking at A, B, and C. That's your 3-3-2 that you'd be looking for. Malampati. So class 1 and 2 predict adequate oral access. Class 3 predicts moderate difficulty, and class 4 predicts a high degree of difficulty. And you can see here in these images that as you're looking at class 1, you can see pretty much all of the airway structures in the back here, right? Or the oral structures. But as you continue to move on, here you can only see the hard palate. You can't see anything else. So this is a really nice, quick way. Again, your patient has to be able to be following commands at this point. So the only way you're going to be able to do this assessment is if they're following commands and willing to work with you. But it's a nice way to assess if you're going to have some difficulties. O stands for obstruction or obesity. So conditions such as epiglottitis, head and neck cancer, blood wings angina, neck hematomas, foreign bodies or thermal injuries, anything that can compromise laryngoscopy, the passage of the endotracheal tube, bag valve masking, or potentially all 3. And you can see here some examples of obstruction or obesity. See, this kind of fits into the first category too. Short neck, you've got a pretty small oral, what looks like would probably be a pretty small mouth. And then in here, you've got a pretty severe tonsillar swelling. So that could tell you I could potentially have some issues here. I want to make sure that I'm well prepared. And then your N is your neck mobility. So neck extension is an important maneuver, even if it's just getting the patient into a sitting position to get an optimal view. We'll talk about positioning in a bit. Neck mobility can be significantly reduced in patients, though, like trauma patients, those that are in cervical collars, and those who are elderly or have arthritis. So sometimes it can be a little bit more challenging, but then we have techniques to mitigate that, but we'll talk about that in a bit. So what if you have a patient in front of you that has an abnormality in one aspect of the London acronym? All that means is that you need to make sure you've got your plan A, you got a plan B, and you got a plan C. You know it's going to be challenging before it even starts, so set yourself up for success. And please keep in mind that you can have a patient that looks fine when you're using this Lemon tool, but it can still be difficult. It can be an unanticipated difficult intubation. So if you treat every intubation as having the same chance of being difficult, then you're setting yourself up for better success. If you think that every time that you're doing an intubation, it's going to be the most challenging intubation that you've ever done, so you're using all of your best maneuvers and your best tools, your best thoughts, moving it forward, that's how you have your best outcome. All right, so now that we've done our patient assessment, let's talk about our equipment. So go ahead and grab a bedside table if you can, or clear off a place in the back of the truck, because you're going to need to start laying out a lot of equipment. And if you start putting it on the stretcher, I guarantee you it's going to get lost in the blankets and the folds and everything else. So this is what you need at a minimum. A BVM connected to 25 liters per minute O2 source, and make sure that source is well sourced. So if you're using the wall, if you're in the truck, you've got enough oxygen. If you're using one of the little portable ones, check and see how much you've got in there. You're going to need a ET tube with stylet. You're going to ask your intubator what size they want. And if you want an extra gold star, pull out an extra one, a size smaller, because sometimes you'll get in that airway and you'll realize that what you thought might fit won't fit. And so it's very nice having one size smaller, readily available so that you can make that transition pretty smoothly. You need a 10 ml syringe for inflating the pilot balloon. You need a Mac or a Miller blade with your handle, and you'd ask your provider what size Mac or Miller blade and which one they would prefer. End-tidal CO2 device, either colorimetric or waveform capnography. Immediately connecting to waveform capnography is the gold standard. So make this your routine practice if you have it, rather than wasting time with the colorimetric device initially and then transitioning to the continuous waveform. Just start right with the continuous waveform. And then you need some type of securement device to keep your ET tube in place, right? And if you anticipate a difficult airway, or if you're just trying to be a really good planner, which is what we should all try to be when we're doing intubations, then we want to start thinking about what some of our other options are and what some of our backup plans are. So video laryngoscopy, that's a really awesome tool to be able to have in your back pocket. A lot of providers use that as their primary intubation technique. The difference there is that you do need to change out that regular stylet that you might have placed for the rigid stylet that's created specifically for the video laryngoscopy use. And then that just allows them to manipulate that tube in a more beneficial way because of the hyperangulated video blade. It allows them to have better manipulation. If they use a regular stylet, it can make for even more of a challenging intubation. A bougie. So a bougie is a device that can be a little bit easier to thread through the cords at times, and then you have your ET tube that slide up and over the bougie. Supraglottic airways, so your LMAs, your Kings, your iGels, those are all excellent backup devices to have. And then a surgical airway kit. That's kind of your last resort in a can't intubate, can't ventilate situation. We'll talk about that a little bit later too. But those are some additional pieces of equipment that you'd want to have. And having worked with paramedics for quite a decent amount of my career, I can tell you that they actually have a lot of really cool backup options and things in their toolbox as well. They would do a lot of nasal intubations and retrograde intubations. And so your providers may talk about some of those things and potentially even plan with some of those things. So just make sure you ask a lot of questions if it's a technique that you've never worked with before. So once you gather your equipment, you're going to want to run through this SOAP-ME acronym to ensure that you haven't forgotten anything. And this is a pretty common one that's used throughout healthcare. So S stands for your suction. Set that suction up and make sure it's turned on, it's turned to high, and it's within reach of the intubator. It's not going to be helpful if it's still tied up on the wall or if it's put in a different area. O, ensure you have enough oxygen sources. So you're going to need one for your BVM, and you're going to need at least one or more potentially for your pre-oxygenation, and we're going to talk about that in a minute. If you aren't using wall mounted and you're using the tank, again, make sure that your tank's going to have enough for what you need. A stands for your airway equipment. Make sure all of the airway equipment is out and easily available. For those high-risk intubations, consider even opening all of your backup equipment as well as your primary equipment. Make sure you ask the provider intubator if you have any questions about what they might want for the intubation or if you feel like something might be missing. But you don't want to have to wait until you're halfway through it for them to say, oh, I need this, and you don't know where it is, you don't know what it is, and that really sets the stress levels up. P's pharmacology. Determine what induction agent, paralytic, ongoing sedation, et cetera, might be used for the patient. And we'll talk about medication and pharmacology more in a couple minutes. But during this time, you want to also make sure that your patient's IVs are working so that when you give those medications, they're going to go to the right place. M is your monitor. So position your cardiac monitor so it's easy to see. Set your blood pressure cuff to go off about every 2 minutes. That's what I used to do. During and immediately after the intubation, and then you can go a little bit longer depending on how their blood pressure does after the intubation. Make sure your SpO2 probe's working, and there's somebody in the room that's going to continuously monitor the SpO2 so that you can alert the intubator if the O2 sats fall too low during the attempt. And usually we say too low is about 90%, but we're going to talk about that a little bit more with the pre-oxygenation phase. And that's really a number that should be determined by the team in that moment based on that patient. And then E, your end tidal. Turn on your end tidal CO2 monitor on that cardiac monitor before your intubation attempt even starts. So as soon as the waveform capnography's device is attached to the EP tube, it's going to immediately start giving you feedback rather than attaching it and then somebody having to go to the monitor and turn it on. All right, so this is our next P, positioning. So patient positioning is very important for your first pass success. And in the hospital world, we're often very lucky and get to adjust the head of the bed, the height of the stretcher, and the location of all of our equipment. Pre-hospitally, though, it can certainly get more interesting trying to optimize your patient's position in a ditch or sitting upright when they're entrapped in a vehicle. So in an ideal world for positioning, the goal is to align the oral axis, the pharyngeal axis, and the laryngeal axis. You can see the difference between what a neutral position is in all of the different axes, what it looks like when the head's elevated, when they're put into the sniffing position, or when they're putting into the ramped position. If you have a trauma patient, it can be challenging because you don't want to hyperextend that neck if you don't know what the injuries are. So this might mean you have to switch to video laryngoscopy, which because of the hyperangulated blade in video can allow for successful intubation with really minimal neck manipulation. And again, if you're in a hospital and you have the luxury of moving the patient in the stretcher, really it's the stretcher. I remember doing some intubations in the back of the truck, and it was always just very frustrating how you'd have to kind of like squat over that captain's chair because you couldn't actually move the stretcher. And so in that situation, you're kind of stuck with with what you're working with, but in a hospital, you can move the bed. So move the bed, bring the patient to the top of the stretcher, raise the bed to waist height of the primary intubator. So you look more like this guy, which is better body mechanics, than this guy who's doing the bend over. Pre-oxygenation, our next P. So pre-oxygenation is used to increase oxygen reserves in order to avoid hypoxia during intubation. Put a patient on both a nasal cannula and a non-rebreather. Now this seems a little weird, but just follow me here. When you set both your nasal cannula and your non-rebreather to 25 liters a minute, and I know what they say about nasal cannulas, they don't go over 6 liters per minute, but we're just talking about an emergent intubation, pre-oxygenation state, go up to 25 liters. Worst thing it's going to do is dry out their nares, and it's only for a couple minutes. And you're doing this to ensure total nitrogen washout of the lungs and establish an oxygen reservoir. You also have the added benefit of having the nasal cannula in place during the intubation attempt for some apneic oxygenation. This means that even though the patient isn't breathing, the active flow of oxygen through the passive lungs can prolong the time before the patient desaturates, giving you slightly more time to complete the intubation. And if you're actively bagging a patient, it can still be beneficial to put the nasal cannula on for the same reason. Now, this pre-oxygenation phase should last about 3 to 5 minutes for optimal effect, and it should happen right before the intubation. So we're not going to do this and then wait a half an hour, and then do the intubation. We're going to get this set up and do the nasal cannula. We're going to put the mask on for 3 to 5 minutes, set up the rest of our equipment for the intubation, and then when we're fully ready, as we're going to talk about in some later steps, we will come back, remove this non-rebreather, and begin the intubation attempt while you can still keep that nasal cannula on. And it just works really nicely. And so this slide, this graph in the slide shows how quickly different patient populations can desaturate during an intubation attempt. The fastest to drop are obese patients and children. So ensuring pre-oxygenation before the first attempt gives the patient the best change at maintaining an appropriate SpO2 for the longest amount of time. If you see here, you can watch as it comes and then it kind of hits this point and drops off pretty quickly. So in a moderately ill adult here, 70-kilo adult, you can see that they can actually go pretty decent amount of time before they start to drop off. But we really just, once we start to see that drop, you can see how rapidly it occurs. And so that's why I said earlier, you want to determine what your lowest SpO2 is that you're comfortable for with that patient before you start the intubation attempt. So if we're starting somebody and they're 100% and they drop to 92%, that might be okay while you're doing an intubation attempt. If you have somebody that's starting at 92% and they drop to 90%, that might not be okay, because that once you get below that 90%, they might rapidly start to decline. And so it really depends on the patient, the situation, their disease process. And so just talk with the provider. What SpO2, what number do you want me to make sure that I let you know, hey, you've reached this percentage during your intubation attempt, so that you can decide if you're going to stop the attempt to try to bag the patient back up again. And again, we're trying to avoid all of this by doing really good pre-oxygenation. All right, our next P is our plan for failed attempts. So you've assessed your patient, set up your equipment, positioned the patient, positioned the stretcher, you pre-oxygenated. You and the provider have a plan, right? Your first attempt, let's say, is going to be direct laryngoscopy with a MAC 3, and you got a 7.5 ET tube. What's your backup plan if this doesn't work? I don't know if this is always really well hashed out. I think sometimes you can get into situations where you haven't had a failed airway for a while. And so it can be pretty comfortable to just kind of say, oh yeah, no, MAC 3, and it's good, we'll get through it. You don't want to wait though until that time where now you're trying to scramble for your backup plan. It's not good for the patient. It's not good for the staff around you. It's not good for the intubator. Everybody gets stressed out about it. Nobody knows what's happening next. You need a backup plan. And so it should always be discussed. And if it's not, it's rather negligent to not have that conversation. So you never know when you're going to need it, because intubations don't always go as planned. And so after a failed attempt, something needs to change, whether that's the patient's position, the blade size or type you're using, the addition of video or a bougie, maybe you change the intubator, maybe you add a supraglottic airway. Something has to change. You should never have an attempt and fail, and then not change a single thing, bag the patient up, and go back and do a second attempt in the exact same situation. Something's got to adjust to try to make that second attempt successful. The vortex method is a really cool way of thinking of airway management. Essentially, it encourages you can really start anywhere. So either masking, supraglottic airway, or intubation. And if any one of them fails, you can circle on to the next. And if all three fails and you're in a can't intubate, can't oxygenate scenario, then a surgical airway is intubated. Now, it can be really stressful if the intubation attempt is not successful. And even in experienced intubators and staff, it can still cause a lot of anxiety. So remember, as long as you can successfully use the BVM to oxygenate and ventilate your patient, there's time to try again and the patient is safe. And if you can't, and you use your backup options and you say, I can't bag, we knew we couldn't intubate, now that supraglottic airway isn't working, then that's when you're talking surgical airway, and that's what your backup plans are for. That's why you talk this out, to know what the second step is going to be, so you can quickly and smoothly transition to it without there being any complications for your patient. Okay, pause. So this might be my favorite part of this whole series. There are some people where, when you ask them about intubations, they'll say that they're chaotic and they're kind of crazy, and there's people yelling and, you know, running around and trying to get things done, and they have to rush. And I truthfully feel like if that's how it is, then you're not running a smooth, well done intubation. Even in the most chaotic situations, it should be calm, thoughtful, and professional. Every movement that you're doing should be well thought out. You should be working together as your team, communicating well, asking for what you need, talking out the plan. There's always time to take that pause and make sure you're doing the right thing by your patient, regardless of the situation. And there comes a point in an intubation where everybody in the room just kind of needs to take a collective moment, take a breath, review all the equipment you have, your plan, the medications, and please vocalize any questions or concerns that you have. I can't tell you how many times that I've seen people where they say, oh, I thought about that before we started, but I didn't want to say anything. Or, yeah, I was kind of worried about that, but I didn't want to bother the provider. Say it. Because if there's a bad outcome and you didn't speak up, the guilt that you have with that, it's not, there's no need. So just speak up. If you think that there's something that needs to be different or you have questions, just speak up. Ensure that everybody in the room has an assigned role and knows what their responsibility is. And once that intubation actually starts, there should be every effort to minimize distractions. So close the door, extra people out. You don't need an entire room of people watching an intubation. So kick a couple people out if they're not actively involved. And then I really feel strongly about using checklists when you're doing something like this, because you don't do intubations enough, I think, especially in our environment, to ever be truly that quick and well-oiled machine. And so a checklist makes sure that everybody gets on the same page. And we use this all the time in flight because you never knew. There was a lot of stress. There were people that you were working with that you didn't routinely work with. You just wanted to make sure that you had a minute to get everybody on the same page to make sure that you were doing the best that you could. It should be read if you have one, and we did make one for this hospital. It should be read as a read and response. So one person would read from the list and another person would verbally confirm, like look and say, yes, suction is on, I see that it's on, I checked the suction, it's on, it's tucked here, it's good. And so this is just an example of what one of those checklists can look like to make sure that you're running through all of the pieces that you would potentially need for this infusion. All right, our next P is paralysis with induction. So in real life, you would have discussed and made your plan for your RSI meds already. That would have been in that pre-planning phase. But we're talking about them now because in the flow of an actual intubation, you wouldn't push any medication until after that pause, making sure that everybody's ready for induction, all the equipment is set up, and we're good to move forward. Because once you push those meds, you can't take them back, right? So let's just start simply. What is RSI? So RSI stands for rapid sequence intubation, which is the simultaneous administration of a sedative, which is also called an induction agent, and a paralytic. This causes the patient to become rapidly unconscious and flaccid to allow for emergent intubation with a minimized risk of aspiration. Now, there's a lot of different types of induction agents that can be used, and each of them have their pros and cons and need to be chosen based off the patient's condition. And you'll have some providers that say, I love this med, I love that med. Just because you love it doesn't mean it's good for everyone. Every med should always be chosen based off of the patient in front of them. So etomidate. Etomidate is a sedative hypnotic agent. It has no analgesic effects, so it will not blunt pain. It's commonly used for intubations as it doesn't cause a significant cardiovascular side effects as some of the other ones. But if the patient's in a severe state of shock, then they can have just as severe side effects with it. It's often not given to children less than 2 years old. Ketamine is a dissociative anesthetic, which means it has both sedation and analgesic properties. It must be given as a slow IV push. If you give it rapidly, it can cause significant laryngospasms, which will cause complications with the intubation. People like to say it's a benign drug and it won't cause hemodynamic compromise, but that's not true. It's not correct. In healthy individuals, ketamine will cause a catecholamine surge, which can temporarily cause hypertension. That's what leads people to think that it won't cause hypotension. But that's wrong. Any patient in a state of shock is going to exhibit the same level of cardiac compromise with ketamine as with some of the other induction agents. Remember how I said that it can cause transient hypertension in a healthy adult that's not in a state of shock? Well, that means that you want to avoid ketamine in any healthy individual that you wouldn't want a blood pressure spike to occur. So that could potentially be your strokes or an aortic aneurysm. Midazolam, it's a benzodiazepine, so it also doesn't have analgesic properties. And you'll see a little later why I keep bringing that piece up. Not typically used for induction, but it is an option. And propofol, it's a lipid-soluble medication that does cause sedation and amnesia, but again, no analgesic properties. Not commonly used outside of the OR as an induction agent because it really does cause pretty profound hypotension and bradycardia in patients that have any type of a compromise, any level of shock. So we typically see it primarily in the OR because they have these really healthy patients that have gone through a robust pre-op process, and not as commonly in the ED and definitely not pre-hospitally. Now, any of these medications, I put on here what the average dose tends to be and the effect and how long the duration of it lasts. But any of these, the doses should really be cut in half in elderly patients and those that you think are going to potentially have significant cardiac compromise. So any of your patients that are in a high level of shock, we should not be using full doses on because you can cause a patient to go into cardiac arrest by fully dosing them any of these medications for an intubation for induction. And then there's two main paralytic agents that we see utilized with RSI. Acetylcholine is a depolarizing neuromuscular blockade. That means the medication adheres to the cholinergic receptors of the motor end plate, and that causes a continuous disruption that results in transient and involuntary muscle contractions that are also called fasciculations. Now, there are a lot of contraindications to using sex, so you want to be cautious when utilizing it. Some examples include it's contraindicated in patients with hyperkalemia, rhabdomyolysis, burns, acute or chronic renal failure, history of malignant hyperthermia, neuromuscular disease, and several others. Now you can see that the duration is only about 3 to 5 minutes on this one, okay? Rocuronium, that's a non-depolarizing neuromuscular blockade. That means the medication is directly competing with the acetylcholine on the neuromuscular receptors, blocking the ability for the muscle to actually contract. So you're not going to see fasciculations with this one because rather than causing all the muscles to contract at the same time, it's not allowing the muscle to contract at all. So while in general, this might seem safer than sex because it doesn't have any serious contraindications or cause any serious side effects, the duration of action can be problematic for some people. As you can see here, it's about 20 to 45 minutes versus 3 to 5 minutes. We're talking about being paralyzed, so that means that they can't do anything. So if we're not watching our patient closely enough, we can actually hypoventilate them after intubation and cause a worsening of their problems because they're now paralyzed for 20 to 45 minutes. They can't overbreathe the vent and do what they need to do. And we're going to talk about that a lot more next month in the vent management lecture. We're going to talk about ABGs and some goals of vent management, but it can really influence the decision that the intubator or the provider has to make about which medication is more appropriate. Placement with proof. All right, so you push your meds, your provider completed the intubation, they say the endotracheal tube is in. How do you know? So immediately after the provider removes the stylet or the bougie or whatever it was that they had used, they inflate the pilot balloon and they say, go ahead and bag the patient. There's a few things we need to do to confirm that placement. The gold standard, check the end tidal CO2. If you utilized a colorimetric device, then it should turn gold. But like I said before, we want to really stress this continuous waveform capnography. This is the gold standard. This is truly the gold standard. Should be connected directly to the patient's ET tube, just like it is here, with the BVM on the back, the monitor turned on so you can see the immediate feedback. So you should see a waveform. So see here, you can see a waveform, and that's the exhalation, right? Because it's CO2, so it's what's being exhaled. And so the number can vary based off the patient situation, right? So sometimes the number can be lower. Sometimes the number might be higher than expected. So a normal is about 35 to 45. So you might see a little lower, but other times you can see it significantly higher. You can see right after an intubation, it opened up at like 60, and you're thinking, why is that? Well, when we made them apneic for the intubation by sedating and paralyzing them, we took away their ability to exhale, allowing CO2 to build up in their system. So if that intubation attempt took a little bit longer and we didn't bag in between, then you can have a buildup in CO2 in those lungs. And as soon as you put that ET tube in and start to bag, and they are able to actually exhale again, then you're going to start to see all that CO2 come out. And so that number should come down with proper and really good vent management. If you have no waveform while you're bagging, you can do a quick troubleshoot, is everything plugged in and connected, but you have no waveform and you're not in the lungs. And that needs to be an immediate attention to the provider to let them know that you have no waveform, and so you're not in the lungs. And then we're going to talk about a couple of other techniques that we use as well that'll help to confirm and support that. We would look for chest rise, misting in the EET tube while you're ventilating. Seeing chest rise tells you that air is going into the chest, right? And misting infers that air is being exhaled. Do realize in kids and small adults, it can be hard to differentiate chest rise and abdominal rise due to their body habitus. And misting can also happen if there's a lot of air in the stomach. So that's why this is an important step to look at, but it's not the gold standard. Other thing we're going to do is listen over the epigastrum and over both lung fields on the right and left side. We listen to the stomach first so we can rapidly determine if the ET tube is not in the right place. So let's say that you had a patient and they had a colorimetric device that you used and it had a positive colorimetric change, right? How could it have a positive colorimetric change if it wasn't in the right place? Well, sometimes if your patient's been manually ventilated for a prolonged period of time before your intubation attempt, so you've been bagging them with a BVM for a prolonged period of time, you can actually get a false positive on your colorimetric device because the excess air built up in the stomach can actually make it turn gold. And so that's why we just always do that waveform capnography. And if you're listening to lung sounds and you don't hear lungs over one side, there's a couple of things that could mean. Either your ET tube is too deep and it needs to be pulled slightly back because it's gone too deep down the right or the left main stem, or maybe your patient has developed a pneumothorax. And so that could be the cause why you don't hear lung sounds because that lung is collapsed. There does need to be confirmation at the time of placement of the depth of the tube. And this can be described at the teeth or the lip. And the tube is then secured at that location and will be used as a reference point moving forward to ensure it's still in the correct place. So it doesn't necessarily mean that it can't be moved because you could obviously have the ET tube in one place and then say, hey, we need to put it in a little further. We need to pull it back a little bit. And you'll hear that happen quite a bit. But it does mean that we're keeping track of it. And so depending on the documentation, some people will document at the level of the teeth, which is slightly more in, and some people will document at the level of the lip. So just make sure that you know which one it is and that you're consistent in that. All right, so chest x-rays are typically done after an intubation and they confirm tube depth, but that's it. So because the trachea lies directly above the esophagus, when you do an anterior posterior chest x-ray, it's not going to show if the tube is in the trachea or the esophagus because they lie on top of one another. So it can be in the esophagus and look good, but it's not, right? So it's only actually showing you your depth. That's the only thing that we're typically using it for a traditional AP chest x-ray. And that's why it's not really prioritized right off the bat, that's for tube placement, right? It can be several minutes, longer than that before a chest x-ray is done after an intubation. Pre-hospitally, you don't do a chest x-ray, right? You don't have the equipment. And you could have a patient that's intubated for quite a long time before they get into a facility to get a chest x-ray. And that's why we have all of those other confirmation pieces that we go through to ensure that it is placed correctly in the trachea. But this can help you determine some tube depth or any other potential challenges you might be having while you're ventilating your patient. So this example on the left is an ET tube that's right main stemmed, meaning it was placed too deep and is only in the right main bronchi rather at the level of the carina. And the carina is where the trachea splits into the right and the left main bronchi. So always a little hard to see. You can see there's a shadowing here and then there's shadowing here. And so that is your carina. That's where that split occurs. Now, if you follow the ET2, this long straight line down, you can see it bypasses that carina and goes right down into the right side. Okay, so this is an aerated lung. You can see some black and then the white opacities at some of the vasculature. And this is all white because it's starting to fill in with accumulation, and it could be filling with, potential some fluid shifting because there's not air that's actually being pumped into there to be able to keep that space nice and open. So this is a good example of when your ET2 is too deep. In this situation, the provider would say, hey, let's pull it back, 1 centimeter, 2 centimeters, however far, resecure it, redocument that is now the new place, reassess, listen to lung sounds on both sides, get another chest x-ray, see if it's improved. If you do have somebody that's main stem, it's typically more common on the right side because that bronchi goes a little bit more straighter after the bifurcation than the left one. It can lead to overinflation of one lung, and that can cause increased pressures on the ventilator and some serious complications for the patient. The example on the right is a patient with a large pneumothorax. So the left lung here is completely collapsed. That's why this black area is so clear. So here you can see a lot of more of like the, what am I trying to say? Like the vascular shadowing here of the actual tissue because it's expanded, versus here it's all clear and black, and that means that there's literally nothing there. Like there's no tissue, it's just straight air. And your heart appears to be kind of squished down because normally it sits up a little bit higher and it has this nice notch up here. So that looks like it's starting to be squished down. And if you look at the trachea, it looks like it's kind of starting to lean a little to that right side, right? All of that's indicative of the tension pneumothorax. Just as an aside, if you were intubating a trauma patient and immediately after the intubation, you're having a really difficult time bagging, it could be that they sustained a minor pneumothorax in their injuries and their trauma, but that positive pressure ventilation made it worse and turned it into a tension pneumo. If you're working pre-hospitally, obviously, you're not going to have a chest x-ray, but you don't need a chest x-ray to confirm tension, and you don't need a chest x-ray to confirm a tension in a hospital either. They have unilateral chest rise, breath sounds on only one side. If they're difficult to bag, they say they can't breathe, they have worsening vitals, then follow the guidelines to treat a tension pneumo. You don't need the x-ray confirmation. You're not going to wait and let that tension pneumo worsen and let that shifting occur more and more just to get the image before you actually do something. You're going to intervene first. But if you do see it on an x-ray as a finding, it is pretty interesting. And then our post-intubation management, right? And this is one that can be really tricky. It can be tricky to manage. So our ET tube is in, we confirmed it, we secured it, our patient's getting connected to a ventilator, and now it's all the next steps. So let's talk about monitoring. We want to make sure that end-tidal CO2 continuous waveform capnography is still connected and still functioning. We want to watch our SpO2 closely as the patient's being transitioned to the ventilator. If they have a dip in their SpO2, we can think about increasing their FiO2, their PEEP, and they might even need their respiratory rate increased based off what they were breathing before. And again, don't forget next month, our vent management lecture, we're going to go into a lot of this in more detail. We're going to reassess that blood pressure. You likely gave a decent dose of sedation for the intubation. So are we still normotensive? Are we where we started? Have we become hypotensive? Sometimes a fluid bolus is enough to turn that patient around, but it's not uncommon for them to require a vasopressor for continued blood pressure management, especially since we're going to need to be adding some sedation on board. Which brings us to the next piece. Remember how earlier when we went over the induction meds, I outlined who did and didn't have analgesic properties? If you remember, ketamine was the only one that had analgesic properties. And then also, do you remember how most induction agents don't really last longer than 15 minutes? So what does that mean? That means that your patient's going to be waking up and feeling pain shortly after the intubation. And even worse, if they received rocuronium, they're going to be paralyzed longer than they will be sedated. So what do? We need to start sedation and analgesia to manage these patients post-intubation. And that needs to happen as soon as the intubation is done. Those meds should be started as soon as that airway is confirmed and secure. Meds should be going. Shouldn't be 15, 20, 30 minutes later. They should be in the room before the intubation attempt even happens so they can immediately be started. It commonly means hanging a propofol and fentanyl infusion and titrating those to effect. There's other medications such as midazolam and ketamine that can also be utilized in infusions. And because all these medications can cause hypotension, again, it's not uncommon to need to add a vasopressor to be able to ensure that there's a proper level of sedation. I can tell you a lot of horror stories about poorly managed post-intubated patients. or the ones that were only on propofol because providers and staff didn't realize that propofol has no pain properties. We want to avoid that. We want to make sure that they're sedated, their pain's managed, they're comfortable. We should be titrating our sedation and pain medication to a nonverbal pain scale. We want to look at their heart rate and their blood pressure, realizing that tachycardia and hypertension are commonly signs of pain in newly intubated patients. Tearing of the eyes, grimacing, thrashing or pulling at equipment, etc. In some patients, even if they seem to be sedated appropriately, will need soft restraints to make sure that they don't pull their ET tube out. All right, so really just as an overview from all of that, there's a lot of information there. Just set yourself up and your patient up for success by doing a thorough airway assessment, prepping all of your equipment, including your backup equipment, positioning yourself and your patient well, pre-oxygenating for at least 3 to 5 minutes before your attempt, creating your backup plans, making sure everybody's aware of them, pausing to ensure everyone's ready to go and knows their role and their job, choosing appropriate medications and doses, placing the ET tube and confirming it immediately, and managing the post-intubation phase of care. And if you can get through all of those pieces, then you're going to have a lot of high success with intubations and managing post-intubated patients. All right.